Good afternoon to you all. We have come to the last talk of the forenoon session. That will be on relapse in Hansen's disease. Now, leprosy is unique in terms of the nature of the causative organism, the chronicity of the disease, its prolonged treatment, and the definitions of cure and relapse. The principal mode of assessing the efficacy of therapeutic regimes is the relapse rate. Now, there are various predisposing factors for relapse, and there is always a confusion between relapse and reactions. To address this, today we have with us one of the eminent dermatologists and leprologist, Dr. Nanda Kishore, who is professor in the Department of Dermatology at Father Muller's Medical College. He joined this institution in 1980 as a junior medical officer and rose to the post of professor. I request Dr. Nanda Kishore to take over the mic.
Thank you, Dr. Satish Pai, for cutting short the introduction. We should have closed now, 1 o'clock, but this is the last talk. But then purposely it has been, I have taken up the last talk because, the bowler who is to bat now, the Tendulkars and Dravids have already gone. So, yeah, even less than that. Because you don't expect a tail-ender to bat for a long time, don't worry. So I'll be just playing 1 or 2 shots and getting away. Thank you. Now, relapse in leprosy. Now, relapse is an ultimate indicator of the efficacy of any chemotherapeutic agent against any disease. That is the ultimate indicator. And it is more important in leprosy because leprosy is a chronic disease. It has a protracted course. And the manifestations are varied. You have tuberculosis at one end of the spectrum, the lepromatous at one end of the spectrum. And at the end point of the treatment is irrespective of the activity of the disease. You don't look at the activity of the disease, you just say it is over, the treatment is over. So naturally, the disease process continues. And when patients come to you with problem, you don't know what to do with that. So it's a very peculiar phenomenon. So it's all the more important. Relapse in leprosy is all the more important and very, very difficult. As rightly expressed by Dr. Shetty, we have been working on this for the last 3 years. Our project is completed anyway. So we had, in fact, in that meeting, everyone put in their ideas and, we wanted to have a protocol, and it was so difficult to say what point shall we take to examine the patient after when he comes back with the complaint. What are the points to be taken? What shall we do it as? And finally we settled down for what is known as, problem areas. That is all. Because we couldn't say whether it's really relapse or anything like that. Now, as far as the definition goes, the medical dictionary says that it's a return of disease after its apparent cessation. Okay. Now, WHO in 1988 said, occurrence of new signs and symptoms of the disease during the period of surveillance or thereafter in a patient who successfully completes an adequate course of MDT. Well, good enough. But Dr. Arundhati in the same year has just modified it. She said, a situation where there is a reappearance of the disease after its complete sustained subsidence. If you read in between the lines, probably you will realize there's a small subtle difference between these two. Sustained subsidence, she said, because if the activity goes on even after completion of the therapy, how are you calling it as relapse, reactivation or reaction? It's so difficult. But if there has been a complete subsidence, patient is very normal, then he comes out with something, probably we can try to see whether it's a relapse or something else. So sustained subsidence she added. So you have treated a patient for 6 months, 1 year, 2 years or whatever it is, he goes back and after some time, after years, he comes back with some problems. So what are the possibilities? Now there are 4 possibilities. One is a reactivation. Now reactivation is actually what happens is the drugs fail to reach some of the bacteria which are still dormant, lying dormant. Okay, they are lying dormant and the drugs have not reached them. And after some time, when the drug is withdrawn, then it multiplies and then you have a reactivation. And this reactivation takes place in those patients who have not completed the course of therapy, who have taken an irregular treatment. Now, what is a relapse then? A relapse takes place usually due to the persisters. So, you have the persisters which are drug sensitive organisms, but they lie dormant in certain tissues, inaccessible areas of the body, and they multiply after a gap and then they lead on to relapse. And these people have completed the course of treatment. That is very important. They have completed the stipulated duration of treatment. So the relapse occurs in those people. Reaction, yes, it is just an immunological reaction of the body to the presence of M. leprae antigens. It can be type 1, it can be type 2. And reinfection takes place in those people who, after the complete cure, get exposed to M. leprae again. Either they continue to live in an area where it is endemic for leprosy, or in a leprosarium, in a milieu, in a leprosy milieu, what we say. So then they can get reinfected. So all these things look nice, but practically it is very, very difficult to distinguish between all these different R's. So looking at the magnitude of the problem, we have certain, the latest statistics what I got was from in 2012, 0.06% per year for MB and 0.1% per year for PB, and then in 1995, 0.77% for MB and 1.07 for PB, and then one more work somewhere in 2005 says 0.84% for MB and 1.9% for PB. The common factor here is that PB has a greater relapse than MB. Now, we have certain incubation period for relapse, so as to know how long we have to follow up these patients. Now, Ekambram, just now in my welcome speech I mentioned about Dr. Ekambram, who has done extensive field work in leprosy. His follow-up shows that up to 55% relapsed in 3 years' time. Whatever the relapse cases, 55% was in 3 years. And this is only non-lepromatous type. And Pandyan et al., again non-lepromatous, found 57% in 3 years. Ramu and Ramanujam, again it is in monotherapy era, these are all in monotherapy era, and he said most relapses in 5 years. Okay, fine. Now, coming to the MDT, there is a multi-drug therapy. In 90, again, possibacillary, Chopra et al. Said it is 2 years in 76.19% of the patients. And then Grosse et al. For MB, median of 9 years. Okay, that means probably the relapse period or the incubation period for relapse for a multibacillary case is much longer than the possibacillary cases. So what are the predisposing causes for relapse? Which patients relapse? Or what is not the patients, what makes you to get a relapse? The persisters. All of us know there is a persisters. Persisters are the dormant bacilli which remain in a hidden area, so the safe havens of the body. You know, we have Dharmendra who has said it is in dermal nerves, then smooth muscles, lymph nodes, iris, bone marrow and liver. And you have the people who have described that, and it's very nice to see that 3 among the 5 are from India only. What is the precipitating cause of relapse? Inadequate therapy. Yes, inadequate therapy. What do you mean by that? Now here, we have a possibacillary therapy, we have a multibacillary. So some of the multibacillary may be wrongly classified as possibacillary and treated. So your classification must have been wrong. So that is one of the predisposing cause. That is the inadequate therapy. Second is irregularity in therapy. Yes, patient who has not really taken the treatment properly. So most of the times a supervised regimen is taken. You people may not be aware of the supervised regimen because all the tertiary care hospitals do not give the supervised regimen, but in the field they give supervised regimen. So only supervised regimen is taken and the domiciliary is not taken. It almost amounts to taking a rifampicin monotherapy. So irregularity in therapy, right? Or he has not completed the duration of treatment, the stipulated duration of treatment. The third one is a dapsone monotherapy. Dapsone monotherapy is one of the cause. Now you may wonder what is this dapsone monotherapy and why should it have been like this? Now, if going back to the 80s, there was an inclusion criteria for introducing multi-drug therapy, inclusion criteria, especially MBMDT, multibacillary MDT. The criteria was all new cases, all positive cases, all smear positive cases, and those smear negative cases who have attained negativity in the last 2 years of time. Okay? In the last 2 years, if they have attained negativity, they were to be treated. But if their attainment of negativity is more than 3 years, then they were just continued on dapsone monotherapy. We had done that. In 85, if we start, we see 83 cutoff. 83 cutoff means if anyone who is negative before 83, we are not including him in that. That was the criteria given to us. So such patients who had received monotherapy, continued to receive monotherapy, relapsed. Patients with a high initial BI, yes, we do see that patients highly bacilliferous 4+, 5+, they certainly have a greater tendency to relapse with the fixed duration of therapy. Greater the number and extent of skin lesions nerves involved, whether be it a paucibacillary, be it a multibacillary, if you have innumerable lesions, and such patients probably will have a greater tendency to relapse. Now what about this patient? Now this patient is a patient who is having a single lesion. Such a huge lesion, I don't think you will get a chance to see this kind of lesion. Single lesion, I'm telling you, this is a single lesion, huge one. Now what does it qualify to be? It's a paucibacillary. So you give them 6 months of treatment. Are we justified? No, I have put him on multibacillary therapy. I have put him on multibacillary therapy, taking my own decision. I can't go by the mathematics or the rule sometimes. And he has improved very well. Because it is very, very obvious that he does not have that kind of resistance. These are all grey areas. This case has been discussed in Delhi. When I was speaking on the resistance in Delhi conference, and this was a case which was discussed widely, and we wanted the ideas from the audience. Someone said it is worth measuring and then making it as one of the criteria. He said work has to be done in this area. The size of the lesion also. That was a discussion in that in that group. Dr. Pai was there or not, I don't know. It was in that Ashoka Hall, somewhere one hall in that Hotel Ashoka. And of course, HIV infection is another precipitating cause. So what are the clinical features of relapse PB leprosy? Skin. In the skin, mind you, we are now looking at the PB leprosy now. Activity of the existing lesion. Now activity is seen as either erythema or infiltration. By infiltration we mean the infiltration of the border, the raised pearly border. Extension of the lesion. That is the lesion which was of a particular size initially. After some years when he comes back, has it become big. It's all easy said than done. How many of us really record the size of the lesion? How many of us have a body map of the lesion? None of the medical colleges have that. Even if a body map is done, it is done so erratically that you don't know what the size is, whether it's really becoming bigger or expanding. It all looks theoretically in the Viva you may say that, all answers, but in reality it becomes so difficult. Right? Extension of the lesion is one of the activity. Increase in the number, again looks, alright, increase in the number, what is great about it? But how many of us really count the lesions? How many of us could have missed some lesions? Even if you ask the patient, he is not very sure. Maybe might have been there, might not have been there. So it's very difficult practically. So again, a meticulous body mapping is essential of leprosy. Probably I will be giving the importance that in my tomorrow's talk for the beginners, for the first year PGs, do I have a basics in dermatology? I will be a little bit telling on this particular aspect of meticulous body mapping and proper documentation. Macular lesions developing satellite or becoming infiltrated. The earlier macular lesions, Ramu likes to always say macular borderline tuberculoid. He says, likes that word, macular borderline tuberculoid. Such macules developing in infiltration or a macule getting a satellite. Now, this is another sign of activity of the disease or a relapse. Skin lesions develop in polyneurotic leprosy. You have treated a patient as polyneurotic leprosy, everything is fine, and after some time, after stopping of the treatment, if hypopigmented lesions appear, that can be one of the features of relapse. Now, this particular on the patient with the lesions on the trunk, this patient came from Shimoga, had been treated for 2 years with MBMDT. After stopping of treatment, he developed suddenly all lesions became erythematous, referred to us. So, taking the criteria of relapse, we don't know what to do. We don't know how the patient was. Is it possible to have a body map of this? Can you apply all your theoretical knowledge into it? Became very difficult. We gave a therapeutic, therapeutic trial of steroids. Well, the lesions faded off. Once we taper it off, it comes again. Then I said MBMDT will start and see. We started. MBMDT with steroid, again some improvement, again deterioration. Then I started the regimen for rifampicin resistant or rifampicin intolerability with ofloxacin, minocycline and all those things. And after 3 to 4 months, he improved beautifully. He is not on steroid. Now he has completed that almost another 2 months to finish those 2 years. He is normal. So are we looking at a resistance there? Must have been, because we had no methods of detecting drug resistance. Just to say the practical difficulties I am telling. And the other lady is another one, which unfortunately could not be included in our study for our drug resistance, because she did not fit into our inclusion criteria, ma'am. That lady with the face, this lady had completed 2 years of MBMDT somewhere in early 90s. After 15 years, she comes back with again lesions, and then again MDT and reactions, and she improves with prednisolone. Okay, that is all. Whether the drug therapy doesn't help, only 5 mg of Visolon is enough for her. So these are all things which need to be probed into. And now we have taken a smear and sent it to Karigiri for drug resistance study. Let us see what happens. So some areas where we really do not know, where we really cannot say whether it's a relapse or is it a drug resistance, difficult cases. Anyway, we need to discuss more, time constraints. Yeah. Nerves, clinical features of nerves, fresh nerve thickening, tenderness of the nerve. If there is a fresh nerve thickening, again, you have to have a meticulous body mapping of the nerves. You should know what nerves were thick during the time of detection and at the time of stopping of treatment. Tenderness of the nerve is again an activity of the disease. Increase in the extent of sensory loss. Again, body mapping, perfect sensory loss in the extremities. Has it deteriorated? You should have a assessment record with you. Then, insidious onset of motor loss can also be a indication or a clinical feature of a relapse. And relapses may occur only in nerves. So you must have a thorough examination of the nerves, the importance of examination of the nerves. Now, we have seen the clinical features of a paucibacillary leprosy. Now we see the clinical features of a relapse of a multibacillary leprosy. Basically, it is a bacteriological positivity in those who are negative. If he was negative, if he has become positive again, no doubt, it is a relapse. Our second one is, most of them are not negative because they have been stopped treatment, and the BI may be something like 1+, 2+, or whatever it is. If the BI becomes more, increases by grade 2 in any one site, in one site, not the average BI, okay, that is again a indicator of relapse. Appearance of infiltration, especially on the forehead, lower back, dorsum of the hands, upper buttocks. Look for this fine infiltration in a patient who comes after many years after stopping of treatment. These are all, they look for those infiltration. Very, very difficult. You should have some experience to look into it. The youngsters may find it difficult to appreciate that infiltration. Okay. So you look for that. And one more thing, we have also seen in many patients here, the lesions over the posterior aspect of the arms and anterolateral of the thighs. These are the areas where for some unknown reason they relapse. Now these are all said by, not by me, they are said by the greatest authorities on clinical leprosy, Dr. Ramu and Dr. Ramanujam. These people have said this. Okay, you must look for this. And we have seen this. We have seen this in our hospital here. When they come like this, small things. Don't, dismiss it off as some papillary urticaria or something. They may be evidence of relapse. I don't want to go in because I think I'll be spending too much time. I can't resist talking about the case which is. So, change in type of relapse. Paucibacillary can become multibacillary. Yes, most of the times it can happen like that, and it takes a longer time. The time duration will be longer. PB to PB when it relapses, it's a shorter duration. Polyneuritic can reappear as skin lesion, that is as borderline tuberculosis or borderline cases. And lepromatous can also relapse as borderline. But we have also reported a case of lepromatous relapsing as borderline tuberculosis. We have reported it. We have the poster is still there. Patient developed a patch with the loss of sensation in a lepromatous case. That's very, very rare, very rare. Now the microbiological aspects of relapse. The continuation. Reappearance of the positivity after the case becoming negative, okay, as I said earlier. Persisting high BI or increasing BI. All right, now here again, it is not the criteria, mind you. Then increase in the 2 plus, yes, BI in any one side. That is, if suppose the earlobe was 2 plus at the time of stopping of treatment, after some time, after 1 year or so, you again do it, it becomes 4 plus, increased by 2 plus in a single area. Then mice foot pad study is very good. In fact, that is the gold standard, as ma'am said. That, and very difficult to do it anyway. Morphological index, which is almost given up now because the reading of morphological index is very, very difficult. There is a great inter-observer variation in that. Then the certain advanced tests like fluorescent diacetate ethidium bromide test, where the live M. leprae stain green, and then the laser probe, mass analysis, ATP adenosine triphosphate measurements, because these are all indicators of the viability of the bacilli. Okay, so all these questions, after all, you have in this, please direct it to Madam in the afternoon. She is an authority on that. We clinicians are more of theory masters in this. Then, of course, the PCR, which has been adequately discussed. What is we saw the clinical aspects, and then the microbiological aspects, histopathological aspects of relapse. Again, Dr. Job is the one who has done an extensive study in this. It's very, very difficult. If there are any pathologists here, I don't know, still sticking on to this CME, must have left too long now. It's very, very difficult. Whenever we send, and we blindly send, when patients come to us after the stopping of treatment, some lesions, we send a piece of tissue to them and ask them, is it a relapse? And invariably the reply comes back, borderline tubercular leprosy, borderline lepromatous leprosy. They don't comment, because they can't comment on relapse. It's not easy. Why? Let us look into this. Because as you treat a patient, what happens is that macrophages develop intracellular vacuoles and then become foamy, because the bacteria inside them disintegrate, and the cell wall is responsible for the foamy change. So the greater the foamy cells, the more the foamy cells, greater the foamy changes, means older is the granuloma, longer is the disease. Simple logic, right? In fact, Dr. Job has observed clusters of foam cells even 40 years after